Hello, I'm Dr. Kathleen Haley. I'm one of the attending intensivists at the Brigham and Women's Hospital in the Department of Medicine, Division of Pulmonary and Critical Care. And I'm going to be presenting popular topics for the boards. I have no financial disclosures, and in addition, I would like to disclose that I have absolutely no influence with any of the course or the test maker faculty, but these cases are all things that come up either very commonly in our intensive care unit at the Brigham or things that have come up very frequently on other board exams. So that's how these topics got chosen. So the general themes that we'll be going over today: medical statistics, ethics, including decisional capacity, iatrogenic problems, medication effects, prolonged critical illness, and weakness in ICU patients. So medical statistics. Medical statistics, you need to be familiar with these two gentlemen. Mark Twain, who popularized, although did not originate, the quote, "There are three kinds of lies, and statistics." And then Thomas Bayes, who was a professional clergyman, an amateur mathematician, and he is the gentleman who came up with Bayes' theorem. First case. You are the attending physician for a 75-year-old woman who was admitted with diarrhea, fever, tachycardia, and leukocytosis. Her symptoms started about a week after completing a course of antibiotics for a urinary tract infection. You're in luck. Grand rounds this week reviewed C. difficile, Clostridium difficile. Approximately 60% of antibiotic-associated diarrhea is caused by C. difficile. Your hospital has recently changed its laboratory assay for C. difficile, and your new assay has a sensitivity of 70% and a specificity of 95%. You send an assay for this patient with diarrhea following antibiotics, and your patient's test comes back negative. What does this mean? The choices are: A, specificity must be put into the context of the underlying prevalence. Since both the specificity and the prevalence are high, the negative predictive value is also high. The patient is unlikely to have C. difficile colitis. B, a specificity of 95% means that there is a 95% chance that the negative test result is a true negative regardless of the disease prevalence. The negative predictive value is therefore 95%. C, the negative predictive value is 68%. D, the population prevalence is 60%, so a specificity of 95% gives a negative predictive value of 57%. Or E, the likelihood ratio of a negative test, likelihood ratio negative, in this assay is 4.9. In this case, the answer is C, the negative predictive value is 68%. Let's see how we get there. So, how do you calculate predictive values, and what do they mean? So a positive predictive value is the probability of whatever your result is, usually the disease, in everyone with a positive test result. And so it is true positives over the sum of true positives and false positives. By the same token, negative predictive value is the probability of not having the item of interest, usually the disease, in everyone with a negative test result, true negatives over the sum of true negatives and false negatives. For our example, and making these grids, which usually they're a scratch paper, very important so you can keep your numbers straight. The actual incidence of disease is 60%. So if you have 100 patients, the actual number of patients with the disease will be 60, not with the disease 40. The test sensitivity is 70%. So that means that you will have 0.7 times 60, 42, with a positive test and a positive patient. Test specificity, 95%. That means negative test and a negative patient, 95% of 40, 38. So for 100 patients, the negative predictive value is 38 over 38 plus 18, or 0.68. Some more definitions that you'll need to be familiar with for medical statistics, and I guarantee you there will be medical statistic questions because statistics are just math questions, but they're tricky math questions, so they're irresistible to the people who design these tests. The sensitivity is the positive test in patients who have the disease at hand. A high sensitivity means few false negatives. The definition is true positive over true positive plus false negative, because those are all the patients who have the issue at hand. Specificity, negative test in patients without the process at hand, usually a disease. High specificity means few false positives. The definition is true negative over the sum of true negative and false positive. The predictive value, as we talked about, is the probability that a given test result predicts the disease or not having the disease. The odds ratio and likelihood ratio, and we talked about that in one of the options for the answers, is it's something that tests the tests. You probably won't have to calculate either of them, but just be aware that a useless test will have an odds ratio and a likelihood ratio of 1, and the further away from 1 that the number is, the better the test is. More definitions. The absolute risk is the difference between the proportions of the patients with and without a characteristic developing the condition at hand. The number needed to treat or to harm is the inverse of the absolute risk. The relative risk, or the risk ratio, compares the proportion of the patient with and without a characteristic who then develop the disease at hand. And the confidence intervals, again, test the test. It is an idea as to how strong the effect is. So to show you these definitions in a real world example, looking at the report of dabigatran versus warfarin in patients with atrial fibrillation that appeared in the New England Journal of Medicine several years ago now in 2009. The annual incidence of serious bleeding in patients on 110 milligrams of dabigatran was 2.71% versus 3.36% in patients on warfarin, giving an absolute risk reduction with dabigatran of 0.65%. The number needed to treat was therefore 1 over 0.0065, 1 over 0.65%, which was 154. The relative risk of serious bleed with dabigatran would therefore be 0.27 over 0.0336, 2.7% over 3.36%, or 0.81. And the confidence intervals in the test, in the study, were 0.69 to 0.93. Therefore, the dabigatran had a strong likelihood of being favored over warfarin. It was a strong effect of this study. Another consideration regarding statistics, an example question, the world's best medical journal has just published a non-inferiority study on a new antihypertensive regimen compared to a commonly used regimen. No overall superiority was shown compared to the usual therapy. In patients over 70 years old, however, the study showed significant decreases in both systolic and diastolic blood pressure using the new regimen. What does that mean? This is an example of a post hoc analysis. Be very careful about these, both when you read the literature and also if you get a question that uses something that could be a post hoc analysis reference. If the subgroup wasn't included in the original design, then you really can't rely upon it in the analysis. It's generally regarding only as hypothesis generating and requires further testing. So the general point for the board is, remember, there will be several questions involving medical statistics, but don't be intimidated. They're just math questions. The old-fashioned word problems that were the bane of my existence in high school. Just learn the definitions, do the grids, we'll be fine. Case 2. Your patient is a 74-year-old woman who was admitted 2 weeks ago with severe sepsis. Her comorbidities include vascular dementia, mild functional impairment at baseline. Her course has been difficult. She's had multiple complications, including respiratory failure and prolonged altered status. Although she is improving, she is not ready for extubation as of this time, and she has failed the past 3 days attempting spontaneous breathing trials due to low tidal volumes, tachypnea, and desaturation. This morning on rounds, your team is discussing whether or not to proceed with tracheostomy. The patient's nurse reports that the patient is, as she puts it, in there, and the evidence presented for this is that the patient provides consistent responses regarding whether or not the patient is pain. It's very reliable and consistent. The nurse advocates that the patient should be part of the discussion about tracheostomy. Of note, your impression is that the ICU nurses and the patient's family are in disagreement regarding the patient's wishes regarding therapy. Your impression is based on the following. The nurses are reporting that the patient is pulling at her lines and the endotracheal tube, particularly overnight, and they feel strongly that this shows that she actually doesn't want the aggressive approach that her disease has been treated with to date. On the other hand, the patient's family, including her healthcare agent, report that she is, quote, a fighter, end quote, and they feel that she would want all possible interventions to treat her illness. On this morning's exam, her vital signs show low-grade temp, heart rate's a little up, 105, blood pressure is 115/65, respiratory rate is a little up, 24, O2 saturation on 35% is 94%. Her exam shows that her chest has bibasal arrhythmias, her heart is irregularly irregular, her abdomen is soft, she has a tiny bit of edema. Her neurologic exam shows her to be awake. She responds to her name and yes, no questions. However, she has several errors on a bedside test of attention. Save a heart. You may be familiar with this test. That's where you ask the patient to squeeze your hand whenever you say the letter A, and then the nurse spells out save a heart, but purposefully using 2 A's in heart. The patient will also follow one-step commands. Strength is very poor, 2 out of 5, bilaterally, upper and lower extremities, although she does move all extremities. And due to her severe weakness, the patient is unable to use a letterboard. And as we talked about, she makes several errors on the Save a Heart bedside test. So, of the following, your next best course of action would be A, consult ethics, since there is conflict between the ICU nurses and the patient's family regarding the patient's wishes regarding her therapy. B, since the patient has a history of dementia, activate the healthcare proxy for the decision regarding the tracheostomy. C, since the patient is alert and interacts appropriately, she should be the person to decide about whether or not to proceed with the tracheostomy. D, since the patient's decisional capacity cannot be determined, activate the healthcare agent for the decision regarding tracheostomy. Or E, consult psychiatry to evaluate the patient's decisional capacity. The best answer here is D. You can't determine the patient's decisional capacity. The information you have at hand actually suggests that she doesn't have capacity, and so therefore you must activate the healthcare agent for the decision regarding the tracheostomy. Let's go over this in a bit more detail. The patient's decisional capacity cannot be determined. However, it is likely that it is impaired, and so her healthcare agent should be activated. So what does it mean that her decisional capacity is impaired? Well, decisional capacity means that you understand the ramifications of the available options, and you can indicate a choice among the available options after weighing the burdens and benefits of the specific therapy that you're considering. It's therefore a sliding scale. It's not an absolute. And you can have capacity for one type of decision. Am I in pain? Do I want pain med? But not for another. Do I want a surgical procedure? Do I want to commit to a long-term ventilator wean? A history of dementia, therefore, or any other cognitive issue, does not automatically exclude a patient from having capacity for some decisions. It's very situationally dependent. The patient's communication right now is extraordinarily limited. She can only answer yes and no. She is unable to use a letterboard, and she has no option for being extubated in time to make the decision in a timely fashion because she is not able to tolerate her spontaneous breathing trials. So right now, you really don't know for sure how she is processing any particular piece of information. Because she is not able to demonstrate the attention and focus reliably on a bedside evaluation, it is also very likely that she is not correctly and accurately processing information. Therefore, if she can't process the information, she can't weigh the burdens and benefits of a given therapy. The actions that she does have, even though she's able to indicate yes, no regarding symptoms, her actions of pulling out her IV lines in the endotracheal tube could have many causes. She may indeed not want to proceed with therapy. She just may be uncomfortable. She may be having episodes of delirium at night. There's no way of knowing what that means. An ethics consultation won't be helpful at this time. Although the nurses and the family appear to be disagreeing regarding their understanding of the patient's wishes, there is no clear evidence to suggest that the family is not correct in their assessment. The role of the healthcare agent is to use substituted judgment, which means that based on their understanding of what the patient's wishes, they choose what they believe the patient would choose for themselves, not what they would hope the patient would choose. But the patient has designated someone as an agent, so the patient has designated someone that they believe will fill that role for them if they cannot make their decisions. A psychiatric consultation will also not be helpful because the psychiatric consultation will rely a lot on the patient's ability to communicate. And since she can right now only communicate on very simple yes-no questions, their ability to help determine whether or not she has capacity will be extraordinarily limited at this time. So you can't conclude that the patient has capacity. You have to, for this decision, activate her healthcare agent. The take-home point based on this case, the decisional capacity is deeply entwined with informed consent. You can't have informed consent without decisional capacity. Decisional capacity requires understanding and remembering the available choices among therapy. You have to be able to rationally consider and weigh the choices. And as physicians, it's very important to remember that a patient with capacity, if they can weigh the choices for what it means for them, is perfectly entitled to come to the wrong choice. They have the right to refuse any type of therapy that we offer at any time. That is an absolute right that has been held in many, many cases in the courts. Another part of being decisionally capable is that you have to indicate a choice. And when there's doubt of capacity, careful bedside assessments can be used to help figure out whether or not a patient can weigh this information. It's a sliding scale, and a pre-existing issue that affects a person's cognition does not in and of itself rule out decisional capacity for all types of decision. And note also, we're using the term decisional capacity, not competence. The two are distinct. Decisional capacity is something that a medical team can assess, and it is a characteristic of a person, whereas competence is a legal term. And so even though in the vernacular, a lot of times the two will be conflated, they're very separate issues. Medicine only deals with decisional capacity, not competence. As a general theme for the boards, be prepared for questions involving ethics. They will arise. The most commonly used ethical analysis framework is the normative ethics framework, and these use the familiar principles of autonomy, beneficence, non-maleficence, and social justice. Generally, if it's a little confusing among the choices, the answer that preserves the patient's autonomy to the best available degree is the way to go. Be aware, though, that since the pandemic that we've recently had, you should also prepare for managing questions involving allocation of scarce resources. This year, in particular, those types of questions may arise. Case 3. Your patient is a 68-year-old man with recurrent lung cancer who was admitted to your ICU 2 days ago. He had been in his usual state of health and was tolerating an outpatient chemotherapy regimen, pembrolizumab and cyclophosphamide, until about 3 weeks prior to admission. He did have a sick contact. His grandson had a cold, and his primary care physician started levofloxacin for possible pneumonia. He didn't have any improvement with that, however. His current symptoms include non-productive cough, fever, and dyspnea. His shortness of breath increased, and he required intubation last night. Bronchoscopy showed gram stain with neutrophils, but no organisms. His morning exam shows dependent rails, irregular heart rate with a 2 out of 6 systolic murmur at the mid-axillary line, no jugular venous detention, and no pedal edema. What is your next step? The choices are A, perform a CT angiogram to exclude a pulmonary embolism, B, broaden your antimicrobial therapy to include antifungal coverage, especially for aspergillus, C, place a pulmonary artery line to exclude pulmonary edema as a contributing factor for the patient's hypoxemia, D, add methylprednisolone to treat possible drug-induced pneumonitis, or E, check a non-contrast CT to evaluate for lymphangitic spread of tumor. The best answer here is add methylprednisolone to treat possible drug-induced pneumonitis. Let's go over this in a bit more detail. So while the patient has a malignancy, his course has been fairly subacute, and that would be atypical for a classic pulmonary embolism presentation. Most of the presentations on the boards will be the classic paradigms, perhaps a little unusual, but generally be things that will be recognizable and not out of left field. The patient hasn't been severely neutropenic for a prolonged period of time, and so he's not at risk for fungal pneumonia. You can pretty much exclude the consideration of aspergillus off the bat. Also, the reported exam really isn't terribly typical for pulmonary edema, so that's less likely, and so the pulmonary artery catheter is not very likely to be helpful. However, he's been on 2 drugs that are both associated with drug-induced pneumonitis, pembrolizumab and cyclophosphamide. The incidence of pneumonitis with checkpoint inhibitors, pembrolizumab as an example, is about 3 to 5%. The incidence is higher, up to 10%, if the checkpoint inhibitor is combined with anti-CTLA-4 therapy. And about 25% of the patients who develop a pneumonitis will progress and have severe pneumonitis of grade 3 or 4. The treatment for a drug-induced pneumonitis is to stop the offending drug and add steroids. Your BAL did not show strong evidence for an active pneumonia. He was on a very good antibiotic for pneumonia. He was on 2 agents that could be offenders. Adding methylprednisolone right now is your best option. The general points for the boards is use all of the clues that the question stem provides. The setup may include some red herrings, but all of the information that you need will be there, but you may have to dig for it a little bit. Be on the watch for a problem that is caused by iatrogenesis. That's his favorite theme among the board questioners. And so if you see something that looks like it's iatrogenic, if you're not sure, that may be the way to go. Case 4. You're the attending for a 56-year-old man, history of diabetes and asthma, who was admitted 21 days ago for pneumonia following H1N1 influenza. His initial hospital course included an emergent traumatic intubation. His hospital course has since been significant for refractory hypoxemia, and he briefly required paralysis and ECMO support, ECLS support. However, he did gradually improve, and he was decannulated 2 days ago. This morning, on exam, he is afebrile and his vital signs are stable. His mental status exam shows him to be awake. He nods appropriately to yes/no questions. His chest exam shows bibasilar crackles and his heart is regular, no murmurs. His neurologic exam shows that he can't move either his arm or legs beyond moving his fingers and his toes to a command, although he consistently and appropriately is able to move both his fingers and his toes, but he can't lift any of his extremities. The question is, the least likely cause of this problem is A, medications, B, low potassium, C, consequence of his traumatic intubation, D, undiagnosed premorbid neuromuscular disease, or E, critical illness-associated weakness. The answer here is the least likely cause. And again, remember, the board questions are sometimes tricky. The least likely cause here would be a consequence of traumatic intubation. Let's go through this. So a little bit about hospital-acquired or ICU-acquired weakness. approximately 75,000 patients annually in the United States will develop ICU-associated weakness from a report by Fan and colleagues in 2014. These patients have a much higher rate of acute hospital costs, 30%, than patients who do not develop weakness, despite the fact that they were in the intensive care unit. The acute hospital cost doesn't even begin to count the cost of rehabilitation, the readmissions rates, or post-rehabilitation support. So it is a very expensive problem. Patients with ICU-associated weakness also have a higher mortality compared to patients who have been in the ICU but who have not developed weakness. In the first year, patients who have ICU-associated weakness have an average mortality of 28% versus 11% in patients who do not develop ICU-associated weakness, and they may have higher in-hospital mortality additionally, although the results in various studies are conflicting in that. So how might that happen? Well, it's not exactly known how the weakness can contribute to mortality, but logically, there are several possible factors here. If you're weak, your swallowing is usually impaired. And if your swallowing is impaired, you're at much higher risk to develop an aspiration pneumonia, which can, of course, be a problem that can contribute to increased mortality. In addition, you'll have a poor cough, you can't control your secretions, you may have problems with hypoxemia, and again, clearing secretions, dealing with consequences of aspiration. If you're weak, you may also have prolonged ventilation with all the attendant problems of that. If you're weak, you also have poor balance. And so rather than catching yourself, if you get off balance, you may fall and injure yourself severely, either by a head strike or by a bone break. Additionally, people who are severely weak have a lot of difficulty to move in their bed, and so there's an increased incidence of pressure ulcer. However, it may be that ICU-associated weakness is not just the muscle being weak, but there may be an ongoing, persistent inflammatory process that is contributing to the weakness. And this inflammatory process may also be affecting the patient's immune system and ability to fight new infections. And so the whole mechanism of mortality with ICU weakness is very, very complex. And it may be much more than what would meet the eye from just the consequences of being weak per se. ICU weakness can occur very, very early in patients who are admitted to the ICU, although it usually is seen after the first week. Up to 2/3 of patients who require the mechanical ventilator for at least a week will show clinically significant findings, and depending on how you measure weakness, over 80% of patients who have mechanical ventilation for at least a week will have evidence of significant weakness. Unfortunately, this is a very prolonged process, and the 6-minute walk test, which literally asks patients to walk for 6 minutes, after 5 years in ARDS survivors, in patients who had the ARDS, was only 70% of the age predicted maximum for patients compared to patients who did not have prior ARDS. So ICU-associated weakness is a bad problem, and it lasts for a long time. There are various types of ICU-associated weakness: myopathy, problems with the muscles; neuropathy, problems with the nerves; and a combined myopathy-neuropathy. The risk factors for ICU-associated weakness include age, sepsis, the duration and severity of organ failure, mechanical ventilation, the premorbid functional status. The worse your premorbid status, the more likely you are to develop weakness. There's some inconsistent data suggesting that women may be at higher risk than men. And there's also inconsistent data regarding the amount of risk imposed by medicines, such as aminoglycosides, neuromuscular blockers, and glucocorticoids. There are several etiologies for general weakness in ICU patients, and not all of it is critical illness-associated ICU weakness. Patients who have primary neuromuscular disease are more likely to become critically ill in the first place because, as we talked about with the risk for aspiration pneumonia and falls, etc., they have an increased likelihood because of their primary neuromuscular disease of developing critical illness. By the same token, a critical illness can unmask a heretofore unknown neuromuscular disease. A patient can have a new but separate event complicating their critical illness that can cause weakness, such as a new stroke or a new embolism due to endocarditis, or perhaps spinal cord ischemia in the setting of hypotension. As we talked about, medications can cause weakness, metabolic derangements, particularly hypokalemia, and as we talked about, the critical illness itself, which is the ICU-acquired weakness. The diagnosis, and this was summarized by very nice mnemonic muscles by Maramatin and Widgix in Critical Care Medicine in 2006. M is meds, U is undiagnosed primary neuromuscular disease, S is spinal cord problem, C is critical illness-associated weakness, L is loss of muscle such as rhabdomyolysis, E is electrolyte problems, and S is systemic illness such as hypothyroidism, adrenal insufficiency, or porphyria. A corollary of ICU-associated weakness is the problem of prolonged critical illness, and the weakness and the prolonged critical illness go hand in hand. The prolonged critical illness is associated with significant morbidity and healthcare costs, on top of the problem of weakness in ICU patients. The recent studies, as we talked about briefly earlier, of survivors with ARDS show persistent physical and neuropsychiatric problems up to 5 years after their discharge from the acute hospital. Although they will have near normal pulmonary function tests by the end of the first year, their 6-minute walk, as we talked about, is significantly decreased compared to their age expectant comparison. Over half of ARDS survivors support significant anxiety and or depression up to 5 years after their acute illness. So these problems last a long time. They have a very, very bad impact on our patients. Predictors of decreased functioning after ARDS, age greater than 52 years old, critical illness-associated weakness, and significant comorbid disease. The take-home point for the boards: be prepared for questions highlighting the substantial personal and societal costs of prolonged critical illness. Case 5. You're the attending for a 58-year-old gentleman who was admitted with respiratory failure due to hospital-acquired pneumonia. He has a history of, quote, red man, end quote, syndrome after vancomycin. His antibiotics currently include linezolid and meropenem. His course has been complicated by agitated delirium and atrial fibrillation with rapid ventricular response. His vital signs during one of the most recent events of his rapid ventricular response were heart rate of 160, blood pressure of 155/70, respiratory rate of 30, no fever. Last night, he had agitated delirium and he was treated with haloperidol at 8 p.m., but his symptoms recurred and dexmedetomidine was added at 2 o'clock in the morning. His atrial fibrillation was treated with metoprolol at 9 p.m., 11 p.m., and 1 a.m., and this resulted in improved heart rate control. This morning, he is calm with the following vital signs: temp 100.5, heart rate 50, blood pressure 85/50, respiratory rate 14, on a ventilator setting of assist-controlled volume cycle, respiratory rate set of 10. Your best course of action is to A, stop the linezolid, B, decrease or stop the metoprolol, C, send cultures to evaluate for a new septic source, D, decrease or stop the haloperidol, or E, decrease or stop the dexmedetomidine. Here, your best answer is decrease or stop the dexmedetomidine. Dexmedetomidine is an alpha-2 agonist used for IV sedation. It has minimal effect on respiratory drive, and it potentiates the analgesic effects of opioids and additionally has mild independent analgesic effects. It's used to treat symptoms of agitated delirium, and its known side effects include hypotension and bradycardia. The take-home point here for the boards is, again, as we talked about with iatrogenesis, look for medication effects as an explanation for symptoms. Several medications have classic side effects like the dexmedetomidine, and additionally, there are also well-known toxidromes both for medications and other toxins. These are all well described. They are fairly common in clinical practice, and similar to statistics, will have clear answers. Irresistible for people who design tests. Classic medication effects include beta blockers and calcium channel blockers with hypotension and bradycardia, In that case, high-dose insulin can be an effective treatment. Calcium channel blockers, of course, can be treated with calcium. Beta blockers also can be treated with glucagon. Methadone is known for a prolonged QTc interval. Linezolid and SSRIs are associated with serotonin syndrome, which has the following signs of fever, altered mental status, flushing, clonus, and rigidity. And if the QRS is prolonged, treat with magnesium to decrease torsades. Severe symptoms of serotonin syndrome should be treated with ciprofloxacin. The effects can be additive, and so one thing to watch out for on the boards is if you find several medications, perhaps an SSRI antidepressant and linezolid in someone who was stable but now has signs of a serotonin syndrome, that's the way to go. Antipsychotics, of course, known for their prolonged QTc syndrome and neuroleptic malignant syndrome. Propofol is associated with hypotension and propofol infusion syndrome. The tip-off for this is that the patient will have a high triglyceride or the blood sample will be noticeably lipemic. Toxidromes and therapies that you should know for the boards include tricyclics, prolonged QRS, treated with bicarbonate drip. Aspirin, a mixed respiratory alkalosis and metabolic acidosis, enhances secretion by alkalization of the urine. Anticholinergics, the classic red as a beet, mad as a hatter, dry as a bone, blind as a bat, full as a flask, hot as a hare. Manage symptomatically, avoid phenothiazines and butyrophirones, and physostigmine can be useful as an antidote for anticholinergic poisoning. And last toxidrome that you should be familiar with is the sympathomimetics, mydriasis, agitation, and hypertension being the symptoms here. Avoid the cardioselective beta blockade because that can worsen the hypertension to a dangerous level. The take-home point for the boards here is that iatrogenic injury is a favorite target for the boards. Be on the lookout for drug-associated syndromes such as drug-associated pneumonitis and known toxidromes. Statistical analysis are an integral part of evaluating any medical data, both for the boards and for general reading of the literature. Decisional capacity is a continuum. Bedside testing can be helpful. Impaired cognition at baseline does not preclude having decisional capacity, particularly depending on the type of decision. Survivors of prolonged critical illness experience many physical and neuropsychiatric sequelae for several years after their acute illness. Weakness following critical illness is common and can be severe. It is an independent predictor of poor outcome following critical illness. No disclosures, as we talked about. Here are some references for some of the topics that we talked about. And I want to wish you the very best of luck with your boards. Thank you for your attention.